Okay, let's talk about this cool case. This was a 40-year-old male who presented with wheezing, cough, and shortness of breath. He has a history of emphysema and he is a smoker. He states that he ran out of his inhalers and medications because he has no money. And he denies other pertinent symptoms, including fever, chest pain, abdominal pain, nausea, vomiting. On physical exam, his vital signs are blood pressure 120 over 75, heart rate 84, respiratory rate 19, temp 98, and O2 sat 92%. Keep note of that O2 sat. In general, he looked well. He was not in distress. His pulmonary exam was non-labored. He had diminished breath sounds bilaterally. Otherwise, his cardiac, gastrointestinal exams, etc., were reassuring. And then a workup included basic labs, chest x-ray, duoneb, and dexamethasone. So these are his chest x-rays. They're interesting. So up here in the top right, the teal arrow is pointing to some lung parenchyma that, at least relatively speaking, looks normal. There are definitely blebs here. The red arrows that you see better on the PA view show gigantic emphysematous changes or blebs that are consistent with emphysema. These are pretty massive. And then the two orange arrows on the lateral view as well show this fluid collection here of uncertain significance. So let's talk about emphysema. This is disease of the alveoli. Okay, it's progressive, preventable, and treatable, if you will. It is characterized by persistent, irreversible respiratory symptoms and typically associated with significant exposure to noxious particles or gas or tobacco. And consider it as a form of COPD. These terms are often used interchangeably. Same with chronic bronchitis. Generally, it's an attempt to assign pathophysiology to the different areas of the lungs and bronchus. Essentially, what we're talking about is permanent enlargement of the airspace distal to the bronchioles, right? So emphysema is a disease of the alveoli. It is accompanied with alveolar wall destruction without fibrosis, which is seen in some other lung disease. Smoking is the most common cause. However, other inhaled toxins can contribute. They cause irritation, inflammation. There's a mismatch between the protease and anti-protease activity, resulting in alveolar wall destruction, reduced gas exchange, impaired airway dynamics, and progressive air trapping. Here are some illustrations of the epidemiology in both the world and in the United States. You will note the darker colors represent more COPD. So in the top map, you can see not too bad in the United States. There are a few areas. In Europe, you can see part of the United Kingdom. You can see down here in Italy and to Eastern Europe. You can see a couple parts of Russia, South Africa here, right? There are areas of smoking where COPD is very prevalent. And then in the US, if you kind of get a little bit zoomed in here, we're looking at the Midwest here, from Michigan down to Alabama, and essentially along the stroke belt here is where smoking is most prevalent and thus COPD. It is the number 6 cause of death in the United States and the number 3 cause in the world. And about 6% of Americans have COPD. However, that number is likely higher as diagnosis is often delayed or missed due to subtle diagnostic criteria. Risk factors. So smoking, hands down, most common cause. There's a direct correlation between the amount of tobacco you have smoked in your life and your likelihood of COPD and emphysema. You can also have exposure to air pollutants at home or at work. There are genetic factors and respiratory infections contribute. More globally, where smoking is not always the issue, there are occupational and environmental pollutants, both organic and inorganic. And then there is a genetic association with alpha-1 antitrypsin deficiency. So you should, for the patient presenting, you should consider when they have shortness of breath, chronic cough, sputum production, or a history of smoking or other exposures. They typically become symptomatic in the 5th or 6th decade of life, but may have been symptomatic previously and just sort of underplaying or minimizing their symptoms. Smoker's cough, as it is commonly called, is typically worse in the morning with all that irritation, and you get vertical and it starts to improve. And then the dyspnea really tends to get worse in the 6th decade of life. That's when the spirometry tends to get worse. You have breathlessness at rest, etc. On exam, the mild and moderate patients is very difficult to diagnose. They have a prolonged expiratory phase with wheezing and coughing. As they get sicker, right, this is over a decade or two, this is not in a short window, they become more tachypnic, breathlessness, and they have weight loss. And then at the end stage, as they're dying, if you will, from their disease process, they develop cyanosis, pulmonary hypertension, heart failure, cor pulmonale. Diagnosis, primarily clinical, right? Smoking history is typically the most common answer, but other exposures and risk factors plus their symptoms. And then spirometry, and you can see an illustration of that on the right. Okay, labs may show hypoxemia, hypercapnia, polycythemia, which is compensatory, increased serum bicarb, which is also compensatory for a chronic respiratory acidosis. Chest x-ray can be helpful to diagnose other things, right? Pulmonary edema, malignancy, etc. And then the findings in emphysema and COPD include hyperinflation, flattening of the diaphragm, increased retrosternal airspace, and bullae. And how do you treat this disease? Okay, well, you have some objectives: managing symptoms, early diagnosis to prevent progression, improving quality of life, and preventing complications. And then all of that to be said, reducing morbidity and mortality. The most ideal treatment is to quit smoking. Some patients will improve just by quitting smoking. Medications include short and long-acting bronchodilators, muscarinic antagonists, phosphodiesterase inhibitors, corticosteroids, antibiotics, mucolytic agents, proton pump inhibitors. Sort of adjunct therapy includes oxygen if they're chronically hypoxic, like our patient, improved sleep, right? Vaccinations to prevent respiratory pathogens, and then finally, at the end stage, lung volume surgery and lung transplant. All right, so what happened with our patient? His labs look great. His chest x-ray showed bullous and emphysematous changes, hyperinflation. The radiologist said they could not exclude pneumothorax, which when we saw those x-rays, they were pretty impressive, not a surprise. CT was obtained. There is no pneumothorax. If you look at this CT, you see all these bullous and emphysematous changes. They're pretty impressive, right? These are gigantic blebs, right? They are pathologic, of course. And then here you see the lung parenchyma, which is actually contributing to gas exchange, but there was no pneumothorax. The patient, his SATs improved without really any significant intervention. He's probably chronically hypoxic given how much of his lung is pathologic. He went home with an albuterol refill, steroid refill, and outpatient follow-up. No antibiotics. He didn't have any significant sputum changes. All right, so 3 key points about emphysema. It is a chronic, progressive, and irreversible lung disease considered a form of COPD. It is highly associated with smoking and the 3rd leading cause of death worldwide. And treatment is directed at preventing disease progression, managing symptoms, and improving quality of life.